My name's Anthony Douglas. I know many of you, not everybody. It's great to see those I do know, and good to see those I don't know for the first time. I'm the independent chair of the Suffolk Safeguarding Partnership. Our brief, as I'm sure you all know, is to do our best to keep children, adults, and really anybody, including professionals, safe in Suffolk. And to do that, we put a network together, and you're such a network that's come together for this really important learning event that is being recorded, so that for other colleagues who can't make it today, the recording will be on our website, so you can listen to it at your leisure. Not that you get much leisure these days. So the subject matter, as you know, is Three Babies Learning Event. And we decided to carry out as a partnership a thematic review of the lives, the short lives for two of the babies concerned, the lives of those babies and their families, to understand better the risks to pre-mobile babies and how we can best respond with professional curiosity, without going over the top and seeing every single mark on a pre-mobile baby as significant harm. We have quite a good, strong framework in the UK of strategy meetings, Section 47 investigations. That doesn't mean that every pre-mobile baby will be taken through the entire child protection spectrum, but it does mean that every unexplained and particularly potential non-accidental injury to a pre-mobile baby is properly explored for its evidence base. This has been a great bone of contention for over 50 years. Babies are obviously the most vulnerable citizens, and they're so vulnerable that they draw out extra emotion for most of us. One of my grandchildren, I suddenly found him halfway up the stairs. He's 5 months, and he'd got there in about an incredibly short period of time, and it just shows the natural risks that growing children subject themselves to in the interests of growing up. The learning event today centres around the thematic review carried out by Maureen Roscoe-Goulson, who's doing the biggest presentation this morning. And the importance of thematic reviews is in child protection work, we see the same issues come up over and over again over those 50 plus years. Poor information sharing, poor multi-agency working in cases that go wrong. Of course, what you don't hear about is the fantastic multi-agency working and the fantastic information sharing in cases which go right. And there's a little bit of both of those in Maureen's presentation today. Once Maureen's made her presentation about the three babies, based upon her thematic review, just to recap, we carry out thematic reviews so as not to go back over the same ground in case after case, but particularly to try to draw out the lessons and how those lessons can be applied from now onwards. It's always better to look forwards than backwards, to quickly absorb the lessons going backwards, but to change practice going forwards. And then after Maureen, we'll hear from Ali Hassi about the reaction and the learning for children and young people services in Suffolk, and then from Cindy Dunkling about the learning for all health services in Suffolk. There's considerable for both social care and health, there always is. And then my colleague in the partnership, Tracy Murphy, who's our professional advisor for children, is going to talk about another baby, KW, because the links between these situations are so strong, and that emphasises the importance of a thematic review. As we go through, Tracy and I will monitor the chat bar, and after the presentations, there'll be an opportunity before 11 to have a dialogue. All 320 of us, as best we can, about the issues that come up for you on the call through the learning event. And if you do make copious comments in the chat bar, which I hope you will, we'll then respond on the website to all of the points made. We won't try to cover them all in the learning event. That will probably be too difficult. And then we'll just pick out perhaps the 2 or 3 that most connect with the 3 babies presentation. Okay, so I hope you have a terrific learning event and by definition learn a lot. And I'm going to pass to Maureen to make her presentation. Maureen may then link to Ali. I'll be the monitor of the links. If they don't happen naturally, they probably will. Maureen.
Thank you. Welcome everybody. It's really good that we've got a fantastic turnout. So I just want to say a few words before I think Tracy, you're going to put the slides up. Well, there's not much for me to say because Anthony's given such a great introduction. But so just to say where I work, I work in the QA team for Children and Young People Services with a lead in child protection and child in need. And as Anthony said, I was asked to do this piece of work by the partnership. So as he also said in the presentation later on, we're going to hear from Ali and Cindy, who have drawn out, many of the key points of the learning. But first of all, I just wanted to talk a bit about the children and their families to put some context around, around the work and to demonstrate really, as we know anyway, how very complex these family situations and lives are. So yes, so could we have the thank you, slides are up.
Hang on, just put them. Yeah, they're up.
Okay, so that's the title. Yes. So if we could just go to slide 2, please. Thank you. So just a quick word about why the review was undertaken and took part, and just build on what Anthony said, really. So what led to this review? All the 3 children were subject to complex strategy meetings, discussions over a short period of time in 2021. This brought them to the attention, clearly, of safeguarding. All babies were subject to a pre-birth assessment, which led to a child in need plan at some point. Questions were raised regarding the depth of the pre-birth assessments, after the strategy discussions, when, we look over what's taken place. So you can see there who took part. So I'm not going to read it out. You can see everyone that took part, whether that was liaison or, meetings. There was over 30 meetings, one-to-one meetings that took place, majority with health and social care. But everyone that took part actually really added value to this piece of work, and in terms of helping me think about what had gone on and, the plans, really. Okay, next slide, please. These next slides, there's 5 or 6 of them actually, bring the children and their parents, as I said, as we wanted to do, into the presentation, and set out really the very short lives of 2 of the children, and the tragedy that their lives ended before they had really begun. Thankfully, baby M survived his injury, and he's doing really well in foster care now, I understand. But just to talk about baby L, as you can see, she was born in Bury St Edmunds on the 2nd of September 2021, was a full-term healthy baby girl with lots of hair and blue eyes. And where you see the personal comments about the children, this has been provided to me by the parents. So I just wanted to put that in. She was a second born to her parents, and she had an older sister who was 12 months at the time of Elle being born. And this was the same dad to both children. She died on the 18th of December after her mum fell asleep holding her on the sofa, and is believed to have been unable to breathe. due to the unsafe sleeping position that night. In addition, there are some concerns that there may have been other factors which would heighten the risks of using this unsafe sleeping practice. So you've got, you know, clearly an unsafe way of sleeping for a baby, and then other factors that were likely to be involved, cannabis, alcohol, all of that would heighten the risks. Can I have the next slide, please? Again, I'm not going to read this out. You can read that, but I'm going to talk around it. So I think it's fair to say the couple had a really on and off relationship, interspersed with arguments and some volatility. As you can see from the slide, there were several known adverse childhood experiences in Mum's life. And for those of you that are not familiar with that term, it's also known as ACEs, so the adverse childhood experience. And this is a really helpful way of understanding dynamic situations, things that happened in parents' lives. So the mum here, she had a very challenging young life, experiencing physical abuse at home, leading to her becoming a child in care at 12, along with her siblings, rejection, abandonment. Her father then died in 2017 in a road accident. He had been the perpetrator of the physical abuse towards her. So, you know, there's a real sense of never having made it right, I think. So she found it very difficult all around. Then we also have father's own history. Although he wasn't known to social care as a child and reported he had quite a positive home life, he had a number of moves. His father was in the army, but he very much felt that he'd taken the path and owned his own actions. So anything he'd done that had taken him into the realms of the police and the courts, he said that was down to him and not anyone else. Can I have the next slide, please? So moving on to baby M. As it says there, baby M was born in Ipswich on the 24th of October. He was a very healthy boy and the first child to Mum, who was then 19, and Dad was 26. M sustained an injury which was determined to be non-accidental, and this was a spiral fracture to his arm. The explanation given by Dad didn't fit the pattern of the injury that the medical opinion advised. So M is now in local authority foster care in a settled foster placement with supervised family time with his parents. So the next slide will tell us a bit more about, you know, the situations for the parents and a bit about the situation that M was born into. So this was a second child for Dad, who'd had a child from a previous relationship who was in foster care in Norfolk with the case in care proceedings. Dad had not been involved in the child's life, but had been contacted by Norfolk as a part of the childcare proceedings. So there was a lot of information that Norfolk held on father. The plan for M after birth was to live with his mum, with father as well, staying in the home of maternal grandparents, who were all going to be part of the support plan. However, M, when born, was living with his parents in Mum's home, where the support wasn't on hand and wasn't quite what the proposed plan was supposed to be. They ultimately had said they wanted to move back to Norfolk with the baby, but they had no accommodation secured at the time. As it says on the slide there, their relationship was you know, quite new. They'd only been together around 2 months before Mum became pregnant with M. They argued but said it wasn't anything more than any other couples, although she had disclosed domestic abuse in the relationship. As it says in the slide, Mum was not known to social services in Suffolk growing up, but she had had issues with depression, anxiety. She thought that because she had some issues sleeping at night, that it would be helpful that Dad would be there to help with the childcare duties. Could I just have the next slide, please? Yeah, so we've touched on the background of Dad, and it's just set out a bit more there. I think this information is quite key. So again, we know that Dad had a number of adverse childhood experiences, and we need to think about and understand the impact on him and his relationships and what that might have meant for any child that he would then go on to have. He grew up in a volatile household, experiencing domestic violence, and as a child becoming an angry person, understandably. He was then accommodated in Norfolk and lived in various accommodations. Referring back to the other child that he had from another relationship, when that child entered into local authority care, there were a number of assessments, and Norfolk reached out to Dad to include him in assessments. The outcome of those assessments were not positive, in the sense that the parenting assessment highlighted some issues, and the psychological assessment, interestingly, highlighted Dad's real difficulty in regulating his emotions, particularly his anger, and that he had this impulsivity, if you like, and he seemed to lack empathy. So putting that into a picture of becoming a parent, it felt that he would likely be an inconsistent parent who could well respond to a child in an impulsive way, and clearly children, babies, would not understand this impulsivity. Okay, next slide, please. Moving on to baby N, who's the third child. He was born on September 2021 and was the first child born to his parents. He was born healthy, and his parents said he had a lovely chubby face. Both parents were young. Mum was 18 and Dad was 17, and say that they were excited, particularly as the pregnancy progressed and they got used to it. They said that he was a happy baby and very alert to everything going on around him, and was beginning to move around a little bit more before he died. He died on the 28th of November after his mum fell asleep holding him on a sofa, and he is believed to have been unable to breathe due to the unsafe sleeping position that night. Could we have the next? Oh, thank you. So a little bit again about the parents. We've said that they were young. Again, there was a number of significant adverse childhood experiences, mainly in Dad's, but some in Mum's, and you can see in the top part of the slide there, the bit about Mum there. But for Dad, he had significant long-term involvement. He grew up in a volatile household, witnessing domestic abuse. This led to significant social care involvement, ending up with Dad not being in the family home, and in the end living with grandmother under an order. More recent child protection concerns for him in terms of exploitation with gangs, and he was known to be really vulnerable and easily led. And I think that pattern continues, in the sense that he's very young, he wants to be liked, he's easily led with other people's ideas. He was subject to child in need until case closure in September 2021, which is around the time when his baby was born. Both parents commented when asked what was the real difficulty for you, they both said it was really hard not having a proper home and being moved or having to move with their baby between both sets of grandparents as dress. And they didn't have a proper home because everybody acknowledged that the accommodation that they had was unfit, it was mouldy, it was damp. Everybody agreed. There was efforts within the plan, the child in need plan, to try to move that along and help them with accommodation. But sadly that didn't happen. And so they were moving between addresses. And so, you know, they felt that they never really had a secure home for him. So can we just move on to the next slide? Thank you. So before Cindy and Ali talk about the specific learning, I just wanted to talk a bit about the things that are on the next slide, which is something different from what they're going to talk about, I'm sure. So the title's not particularly great, but I tried to throw my net as wide as I could. So learning for practice and systems. So working together. I think all of us on this call will understand the importance of this as professionals. But this review really highlighted and valued, showed how valued it is by all agencies. And I'm going to hone in on social care and health because they were the two main agencies involved here. And, you know, in conversations with both sets of professionals, everybody really acknowledged, you know, the strengths of one another's work and how good it was when it worked well and they worked together. And it seemed that this system works best in child protection work when there is another layer almost, and whole service, which is safeguarding, dedicated to the coordination of meetings, minutes, timescale, sharing of plans. It felt working in child in need can sometimes feel disjointed, and both recognise this. And I think time and capacity is always present. And so there are always barriers and challenges, but we all want to do better. And I think, you know, working together is also about relationships with professionals. Just as we have relationships with families, we want to build and maintain those relationships with our colleagues. I'm not going to talk about it too much because I know Cindy will talk about it, but the things in child in need which sometimes appear more difficult because there aren't the systems there that we have in child protection, and so it's sometimes harder to for example, the sharing of minutes, reports, home visits. These things are really crucial. So I just wanted to touch on that, and a positive of the review was that people really acknowledged one another's strengths. I just wanted to say that. And I think also, you know, there's no suggestion that any plan could have, whether in SIN or CP, would have prevented Ellen N's death from those unsafe sleeping practices that happened on those nights, which were decisions that were made that those parents will regret forever and you know, do regret terribly. But professionals measure risk by the type of plan that is in place. And I think that's why those conversations between professionals is really important when thinking about planning and directions of where a case will go, whether it will be child in need, what that means, whether it will be child protection, what that means. And those professionals that are supporting that family, whether they're a health visitor, a midwife, the social worker, have those conversations with each other. And if people aren't understanding why the proposed plan is being proposed, that they have those honest conversations with each other. And that's how it should be, I think. So a bit about plans. Oh, I've already got straight into plans. That's one of my foibles. I stray into the next item. But anyway, plans. So the known information, just wanted to say, you know, when we look back over it, and also the information that could have been obtained, almost all professionals felt that there was a need for a plan, which, yes, could have supported, but importantly, time for stress testing before we think about closure on any newborn case or unborn case, because it is still an unknown quantity, especially in situations where the baby's not yet born. We don't know if the predictions or the likelihood of what we've, you know, what the plan says, how is that going to come together? And sometimes we know time is precious, but sometimes we have to give it that time. Ultimately, families measure plans by if it is helping them. And that's what struck me when I sat down with the families. You know, it didn't really matter to them, you know, what plan it was, although they acknowledged that the fact that they had child in need plans meant there were positives. There had been positives seen in the assessments. But ultimately, you know, the plan just needs to be safe and workable, and whatever end of the spectrum that is. And thinking back to baby N's parents, what they said that they needed from their plan was a home. And so for them, the plan wasn't successful. And I think, you know, those takeaway points of when we make plans, we know it can be really difficult to see those plans through, and we're not working on our own. We can't push through housing, we can't do miracles. But I just think sometimes, you know, we need that time to see the plan through and make sure that those parts that are really important are completed, if possible. So the next bit there is temporary accommodation. So I just wanted to touch on how, you know, families, we hear things about, oh, it's a housing issue, and you know, it's accommodation. There are no other issues, although often there are other issues, but anyway. So I wanted to touch on how temporary addresses, perhaps in some cases, need to be viewed through what we call a situational risk lens. So I'm trying to understand that it can be more than a house move for vulnerable families. It can mean more than a house move. And so the social and environmental factors could have an effect on this baby, on this newborn, totally independent of any other risks that we might be thinking about. So, you know, smoking, low birth weight, all those things that we know about babies that will be a risk to babies. The actual fact of being moved about, and so and overcrowding and temporary accommodation. So when we see this, we need to think about this and factor it into assessment, and what implications it might have for families and their children. Impact on professionals. A real strength in the review for me was the professional engagement, and I was very grateful for the time that people gave me. Interviews have been a real opportunity, I think, for reflection, for myself and hopefully for others, and discussion about wider practice as well as unpicking the case. For some professionals who weren't involved with the family at the time the baby was injured or the time of the deaths, for some of those people, it was the first opportunity for them to discuss what had happened to those children and how they felt about it and any impact on them. And part of me was quite taken aback by that the first time that they were speaking about that was in a review. And one colleague said, do I have the right to be upset? You know, this is not my this is not my tragedy, this is the parents' tragedy. And yes, it is, but I think the acknowledgement of the impact on professionals of this kind of work is really important, and that colleagues need a space, an opportunity to talk about their feelings, and that might not be, could be in supervision, but I think it would be good if there was an opportunity when events, tragedies like this occur, for people who have been involved or who have recently been involved and maybe not have current involvement, so they can be sensitively notified and supported, and importantly reassured that their emotions are valid and it's okay to feel this way. We're human at the end of the day. Lastly, but really importantly, family involvement. This review asked parents to talk about the most horrendous, painful time in their lives for N and N's parents, and for all of them to reflect on their lives and the agency's work with them and what they thought about it. So I hope people will have a chance to read the report because it goes in depth. But just to finish, really, they all said that they felt, and thinking about this is thinking about assessments and work, they all independently said they needed to feel that they were very careful about what information they shared. And it was important to say what the services needed to hear, especially when it came to social care. And this really is not about individual social workers or practitioners. It's about the perception and understanding that the parents had of social care. And I think we need to continue to be aware of the power imbalance between agencies and parents, however open and honest and respectful professionals are, and you know, strive to be, that fear, that perception is in parents' minds a lot of the time, and this is what they told me. So I think you know, when we're gaining that information from them, we need to have in our mind that, you know, the reasons why people sometimes say the things they do, and therefore it's really important that when assessing risk, that we go and not only check out the information that we've been given, but also have that understanding of why they may not have gone the extra mile in sharing that full information with us. Is it because we're being misled? Maybe. Is it because they're frightened? Very probably. And I think that knowledge is really important. And I think we hear a lot about relationship-based casework. But I think before we have that, or alongside that, we need to have the awareness of the power in all work, obviously, but we're talking about pre-birth assessments, and the possibility in parents' minds that they could lose this child, you know, that the state could intervene, and that will always colour the information that we're given. Parents acknowledged that services and plans were largely positive and that they were SIN plans, and so no real concerns had been identified, but they did say they didn't really understand what the assessments had been about. One dad, that was baby N's dad, said he knew it was because he'd had a social worker, but he didn't seem to know or recall that there were other factors too. And once we talked about that, both parents said, well, that kind of made sense, and they understood that, but said that had they known that before, they would have understood better about what all the questions, all the work was about. So I think I've come to the end of my slides. So thank you. Is it me now?
Yes, Ali, sorry, yeah. If you move on to you, Ali. Thank you.
Mute. Actually, I don't know if you... Oh, he's gone. I'm just going to start. Okay.
Yeah.
Maureen,
a really helpful commentary to the report. So so thank you. That was really good. Okay, can you see me okay, Maureen? I'm just asking you because you're there.
Yes, I can see you. Yes.
We can all see you, Ali, and sorry to be on mute for that, but yeah, I was just going to thank Maureen and say we'll all be around, including Maureen and then Ali, for the Q&A at the end of the webinar, which is finishing at 11. So we'll all be around, so do make use of us. If you think we can respond to any point, put it in the chat. Over to Ali.
Lovely, thank you. Okay, so I'm Ali Hassi. I'm Head of Children's Safeguarding with the local authority and one of the representatives from the CYP who sits on the Suffolk Safeguarding Partnership. Okay, so I'm looking at this from a CYP perspective. Obviously, the learning really goes across the board. I also just ought to say it's raining very heavily here, so I'm hoping that doesn't interfere with what you can hear, but do make it known if it does, and I'll lean really close to the microphone. Okay, so I want to pick up on a few areas of the review. I'm not picking up all of the recommendations, all the practice points individually. They are there for you to read, but I'm wanting to look at some headline messages that I thought were really important that I want to make sure you hear and I can talk about. Some of these points overlap. I'm touching on some of the stuff that Maureen has already said. And probably fundamentally, there isn't really anything new here. These are issues and challenges that we've heard before. And obviously, we're applying them to these three babies in this post review. I want to say first of all, though, and as was said during the Star and Arthur webinar, for those of you who attended that, social workers, as other practitioners we work with, but social workers carry out a tough job where people are unpredictable and not always honest. The work can be draining and it's often highly emotive as well. But I very much want to reiterate that this review, as all reviews should be, are about systems, about development and about learning. So whilst this learning may well have an impact upon anybody who worked directly with the families involved, and I think Maureen told us about the impact that we know that some practitioners for sure did feel. Please know this is about learning, making differences and embedding lessons, taking them forward to the work that we carry out in the future. I'm a social worker. I just want to say I'm proud to be a social worker. And in spite of when and where things go wrong, we do know that the work that we carry out does lead to better outcomes for many, many children and will have undoubtedly saved the lives of many other children as well. So please do hear the following with an open mind as to how you can apply the findings that Maureen has talked about and that I'm going to talk about and Cindy will talk about in the review to the work that we do day in and day out. I want to acknowledge capacity and competing priorities. We know that for all of us, they exist. We're having to juggle things all of the time and look at what is a priority. And those challenges are not lost on me at all. I share them as well. But I'm very much talking about my view of promoting practice within the context of this review in a way that underpins strong assessment practice that will safeguard children. Okay. So I'm going to start with saying, check it out, triangulate it, test the information that you've shared. Maureen has said, and I'm going to repeat, parents will not always be honest with us. Sometimes that's because they are scared. They might live quite a chaotic lifestyle and be genuinely mixed up and confused for whatever reason, so that what they may tell you may not be correct. But at other times, they won't be honest for more sinister reasons, sometimes by being manipulative and sometimes deceptive. So when any assessment is being carried out, but obviously we're talking about pre-births here, and my dog's joining in, apologies if you can hear her. It's crucial to test the information being shared by a parent. It's imperative that the information that you're given within an assessment is triangulated somewhere with other professionals or with other family members. Test it, just check it out, what they're saying, and not take it on face value, what's being said. Really important to use supervision. So for both the supervisee and the supervisor, you know, that's the place where the information gathered so far can be unpicked by that supervisor with the supervisee, to support the practitioner's reflection and understanding of what the information being gathered so far. What does it mean? What's it telling us? You know, supervisors are unable to set the direction of where that practitioner needs to go, you know, further in the assessment. So really think about that. You know, when you get, that's your opportunity to say, I'm not sure, or, you know, what can we make of this? What are we seeing here? Next slide, please, Tracy. So as you'll read this when you read the report, hopefully you'll have time to be able to do that. But in one of the pre-birth assessments, although the mum said to us she wanted to be assessed as a single carer, the father was really very much in and out of her life, and therefore would be in the child's life. And we knew that this couple had an on-off relationship. So although saying I'm single within the pre-birth assessment, the mum spoke about dad playing a very active role in the baby's life. She was talking about how excited he was to have this new baby. So when you hear things like that, we need to think about, is this really a parent caring as a single mother? Is she isolated with no other adults, as she was telling us? And we really need to assess the circumstances into which the baby is being born into. So, you know, at the Star and Arthur webinar, and indeed within the Child Protection in England report, it's highlighted that the records of adults in children's lives need to be explored to gain a picture of who is around that child. And that includes other children who are not part of the immediate family of the one that you're assessing. So information on this particular father's other child, which was on our system, reveals that he had a conviction for causing harm to a child and was considered to be a high-risk domestic abuse offender. So even if that parent isn't engaging within the pre-birth assessment process or any assessment, that information is really relevant to include within the pre-birth assessment, because it tells us about the environment that that child is going to be born into. Also to think about that alone hits the criteria for section 47 and the likelihood of convening an initial child protection conference, given that the procedures that are on the SSP, the Suffolk Safeguarding Partnership website, and they state that an ICPC should be convened if, and I'm quoting, a person who is identified as posing a risk to children, lives in the household, or is known to be a regular visitor. So in another of the cases, there was information that dad had been ruled out in his first child's proceedings. So whilst technically he hadn't had a child removed from his care, and I understand he hadn't even been aware of that child's existence until the court proceedings had commenced, an assessment undertaken of him in another local authority had not recommended him as being able to provide care. So the child hadn't been removed from him, but it was assessed that he shouldn't have care of that child in the first place. So this then also hits the criteria for section 47 and the likely convening of an initial child protection conference. In both cases mentioned, the threshold was probably hit for section 47 and ICPC, and I would urge a quick familiarisation with procedures, and possibly that's something that could be done within a team meeting, but be really useful just to revisit those procedures, around child protection, just to familiarise yourself with what's actually in there. And as Maureen said, all of that said, whilst being child protection may not have changed the outcomes of what happened, the situation in the case, if we are coming from a child protection angle, you know, the case in the family is then looked at through a different lens, and one whereby a child requires protection from harm as opposed to, or in addition to, support. And that may well lead in the future to a different set of actions being taken. And the final slide for me, please, Tracy, if you can move on. Thank you. The pre-birth assessment tool is really a comprehensive tool based upon Martin Cook's framework. A pre-birth assessment is an intricate piece of work. Usually it's hoped you have time to complete this over many weeks. We know that, you know, when referrals come in and when parents tell you that they're pregnant isn't always going to be consistently at a 12-week mark. So we do have to juggle that, as we said, it's unpredictable. But hopefully you'll have time to complete that over many weeks and several months, but certainly before the baby is born. So there is enough time to use it to inform planning. So I really want to impress upon people that are listening that that is a tool, assessment tool. So this tool, use it as a tool. There's guidance that goes with it on the good practice in children's services, and also embedded into the template on liquid logic. And I know that partners won't necessarily have any access to that. So I'm really speaking to social workers there. But use those guidance documents to help you think about what you're trying to get to, what you're trying to probe, what you need to understand and learn and understand and get to. It's something you can feed your information into and then look at it, reflect upon it. What's it telling you? What is that information telling you about the risk and how any risk is mitigated in that family? Then it can properly inform planning. So just a couple of telephone calls or a telephone call or a visit is really insufficient to inform what needs to be a newborn baby. More within maternal and paternal families, and other professionals' insights can be explored to help build a picture of the family to which that baby is being born, and will also inform analysis of the risk, of the vulnerability, and of any mitigation and strengths and safety. So this links to the earlier point made about others who are involved or who have had involvement in the family's lives, which needs to feed into that assessment. So finally, nearly there, Anthony. Finally, I want to talk about children who become parents while still children or young adults themselves, and especially those, as Maureen mentioned, with adverse childhood experience. The perceptions Maureen has noted within the review that in particular is interesting. So for practitioners, we understood that there was a good and open relationship with particularly the father, but with the parents. But when explored in greater depth with the father after the incident with his child, he reported feeling patronised. And I think it says for all families, there was a fear their children, their child would be removed. So this particular father, aged just 17 when his baby died, had only ever known social care involvement during his life. His own CP plan had ended 3 months prior to the birth of the baby. And we know for all of us who are parents that becoming a parent for anyone is hard. It's hard, really hard. So think about the pre-birth assessment, including the parents' own history, how they make sense of their own past and what this means to them in terms of being a parent. And the parents' own needs on becoming a parent, especially while still a child themselves, is very pertinent to ensuring the right support is in place for that family. So I'm just going to end by kind of repeating what I said at the beginning. Social work's tough. Assessing how a baby is going to be cared for when you don't have that child is a skilled piece of work. We know social work is one of the highest risk jobs for burnout and stress, and we don't always feel valued. So you are valued. All practitioners are valued. And as the Child Protection in England report highlighted, there is good practice up and down the country every day, which we know we see in Suffolk too. So I hope this reflection will be of use to you in taking learning forward. And as Anthony said, around at the end, we're always happy to be contacted on email if there's any queries about anything that I've said. Thank you.
Yeah, just to reinforce the point that child protection is everybody's business, and in the partnership we have equal status between social care professionals, health professionals, police professionals, education professionals, and also, of course, families. And Ali referred back to the Star and Arthur webinar when the people who knew what was going on to children were the children's relatives, particularly their grandparents. And so it's important to see the potential for a team around each child protection incident and to really understand who has the information and the evidence base. So for the health professionals' response to Maureen's presentation and the Three Babies Learning event, I'm going to pass to Cindy. Cindy.
Thank you, Anthony. So yeah, I think similarly to Ali, my background is as a health visitor, so frontline. I mean, I'm not a social worker, but we both come from frontline backgrounds, so we have both experienced working with families in that situation. So I'm a health visitor by background. I'm also a paediatric nurse. And currently the designated nurse for safeguarding children and child death reviews in Suffolk. I've obviously looked at this from a health lens, but the things that I've drawn out, you might draw other things out as well. So I would advise everybody to read the report in full if they haven't already. Can we go to the next slide, please, Maureen? Not Maureen, Tracy, thank you. One of the key aspects for two of these children was around the sleeping environment and the associated risks with that. Sudden infant death messages would have been given to these families and in fact were. So we have to ask ourselves why that advice didn't get followed. For both of the babies that sadly died in these cases, their sleeping position, their final sleep, was never the intended place for them to sleep. So there was a change in circumstance or a change in what the family had planned to do. So despite a significant reduction, and that's because of all of the campaigns and good work we've done since the 1990s around the back to sleep, where babies were advised to sleep on their backs, feet to the end of the cot, there are at least 300 infants that die suddenly and unexpectedly each year in England and Wales. We do give safe sleeping advice, but that does need to be embedded with respectful and authoritative relationship-based safeguarding practice. And by that, I mean it needs to be individual, looking at the situation with those families and really talking through what the advice is and making sure that it relates to their real life and what they are experiencing. All our health professional teams who come in contact with parents or parents-to-be should know what that advice is and feel confident and up to date with being able to give it. The guidance that you give needs to be clear, it needs to be relevant, and it needs to be individualised for that family and their situation. Known risk factors such as smoking, drinking, taking drugs, and co-sleeping must be addressed with parents. We know that the risk of co-sleeping alone without these other factors is not, there is no evidence to say that that does increase the risk of sudden infant death. However, you add any of those factors in, and then it does significantly increase that. The risk of sudden infant death needs to be included in any health assessments that are done by healthcare professionals for child protection, child in need reports. So when we're thinking about doing those assessments, if we know that there is smoking in the household, drug taking, drinking, for a new baby or a baby to be, when we're thinking about those plans, it's our role as healthcare professionals to really raise that as a risk and really think that that message needs to be repeated in every interaction with the parent. Can we go on to the next slide, please? One of the things that has been raised by Maureen and also by Ali is around that understanding and supporting of parents. We need to understand what their own lived experiences were and any trauma that they've experienced themselves growing up or in their adult lives. I think we've probably all heard of the term trauma-informed practice, but if you haven't, I would advise you to go away and look it up. It's about trying to understand parents' behaviours and how you interact with them when they have experienced those adverse childhood experiences. We also need to be very mindful of fathers and partners. We've clearly seen that they are an important part of these babies' lives. However, a lot of focus tends to be on mother and baby, and fathers and partners tend to be not always ignored, but perhaps maybe not felt as the equal when we're assessing risk, when we're supporting, when we're giving advice. That's really important in health, that we understand who the significant others in a family are, so that we're able to give that advice to everybody who has caring responsibilities for the baby. Family networks and family dynamics are also essential, and it's important to know what they are. Sometimes assumptions are made that families are supportive and will be there as a help. However, if the parents aren't seeing that as supportive or don't feel that as supportive, then it probably isn't. And it's about trying to sort of dig a little bit deeper and explore with families what life really looks like for them, what their support networks really are, who they can turn to, who they can rely on. Safeguarding supervision in health is embedded for all of our healthcare practitioners who carry a caseload, so our health visitors in this particular scenario. That supervision doesn't have to be on your own with your supervisor. You could certainly reach out to colleagues and others who have involvement with the family, the other professionals working with them, and maybe put together a reflective session where you can be with your supervisor or another lead within any organisation to really talk through and understand what things are like for these families. We only get sometimes a snapshot of our relationships because we're so busy and time is short. You might not see a family long enough to really build that relationship. So having a sort of joint supervision session with others involved is really going to build that picture and help better your understanding. Respectful challenge. I think if you're giving advice, particularly if you're giving advice to a family, say around safe sleeping, as you were, it would have been in these situations, you know, if they're saying it's all fine, there's no issue, I think sometimes respectfully challenging that. Okay, so what happens when you are staying over at this family's and you're only got the sofa to sleep on? Where does baby go then? How do you make sure that you don't fall asleep with baby on the sofa? What can you put in place? Having those kind of conversations. And professional curiosity, we've spoken about a lot within different reviews that we've done, how not to take things on face value, and think a bit more about why things are happening. What's the circumstances here we need to be aware of? So looking into research that's been done nationally, I found this quote really helpful. A better understanding of parental perspectives by all professionals enables local areas to adopt a more flexible and responsive partnership with parents. And that partnership and that relationship is absolutely key. Can we go to the last slide, please? So as Ali and Maureen have said, working together is essential to help support these families. And clearly professionals did work together in these cases. Health visitors themselves are the key professionals working with parents who have new babies. They're able to offer support and informed advice from the antenatal period until the child starts school at 5. Joint visits with social workers would have been really helpful within these situations to the parents and parents-to-be. It would have reduced risk and enabled holistic assessments to be completed. We understand that your time is stretched and you're not always able to do all of the things that you would like to do as a professional. However, these joint visits, the the value to them is so great that prioritising those and speaking with you know, the senior management within our 0 to 19 service, they can see these as being really helpful. Health professionals should request a hospital discharge planning meeting for a child in need case as part of the plan, particularly for younger parents and parents with other vulnerabilities, including where there are several addresses and there's uncertainty. And again, looking at the national research, working together with parents includes the quality of relationships between a skilled professional and a family is key to the engagement for meaningful change. This is not something that can be achieved in a short term. So working together with each other, we can help build those pictures. We can draw on each other's contacts and relationships to really get a full understanding of what life is like for these families and how we might work with them better. I think that's me done.
Thank you, Cindy. And we're now going to pass to Tracy, who's going to cover the KW case that links very much to the 3 babies. So over to Tracy.
Yeah, thank you, Anthony. Yes, we've included this baby because there were so many links and so many similarities between the other 3 babies. So just a quick summary here of the baby and the parental situation, home situation. So he was a baby boy and he was born on the 8th of March 2022, and then he was admitted to hospital kind of less than a month later on the 6th of April after the mother found him floppy and breathless. We don't actually know how that injury came about, but there clearly was an injury. The history of the parents is so similar to the, particularly to baby Elle's mother and father, and in fact, you know, similarities to all of those 3 sets of parents. They were very young parents. They were 22 and 18 when he was born. Mother had a history of, I suppose we would say again, adverse childhood experience of self-harm. She had suicide attempts. Father also had a history of substance misuse. And mother, as it says there, had a chaotic childhood and lots of periods of homelessness, and had been living on her own since she was 15, so had been surviving on her own and had very little support. And there was actually no support network for the family, which was a significant factor. She'd also had contact with NSFT and was on the waiting list for an ASD assessment, which is for autism. So a lot going on for that mother in particular. 2 days after the baby was born, the midwife service put in a referral to Customer First because mother had said she wanted to punch the baby in the face because she was so tired. So clearly, you know, as we've all been saying, being a new parent is so difficult, and she was a very young parent. Yeah, so that's what she said to the midwife. And the health visitor also noted that she had said prior to the baby being born that she wanted this baby to be in a routine from day one. So quite unrealistic expectations, and perhaps a lack of understanding as to, you know, just how babies are and that they're not in routines from day one. And NSFT, as it says there, noted that she was traumatized by the delivery and she was experiencing nightmares and flashbacks. So there was a lot going on for this mother in terms of being a new mother and her parenting and parenting skills. Just to say that the baby is now in foster care with foster carers and also the care of the child in care nursing team. So those services involved with the baby and his family are listed there. So largely the services that were involved were, as you can imagine, were health services, were midwifery, health visitor, healthy child practitioner, and we know she also had NSFT support as a mental health team support as well. Following the referral that went in, that led in MASH to a social work assessment, and a home visit was undertaken a few days later, and but the problem was that the social work assessment, wasn't completed before the end of the 45 days, before the injury. So the injury occurred before the social work assessment was completed. So it wasn't fully done in terms of, it wasn't fully found out in terms of what was going on at home from social care's perspective. So the lessons and the learning, just a sort of summary of the lessons and learning, again, so similar to the other cases, that initial contacts with the mother were not face-to-face, they were by telephone. There had been some visits so that they did know what the state of the home was like and they had met mother, but quite a lot of the initial contacts were on the telephone, and it would have been much more helpful if there'd been regular home visits from the health practitioners. The discussions and decisions between the health staff weren't always documented in the client records, and we've had so many cases where we have seen examples like this and it is difficult because health services are often on different recording systems, and that is difficult to try and ensure that you are recording and making that accessible to all the other professionals that are involved with the case. But in this instance, they weren't recording everything in the client records, and the evidence of any liaison and contact between those staff was quite limited. So that is really about conversations, making sure people have conversations as well as recording. Again, what we've been saying in the other cases, home visit, the importance of home visits, the importance of conversations between professionals, building those relationships. And the third point here is about relationships, multi-agency working, sharing information across the health staff, to ensure that the social workers were informed, because the social workers didn't know of all the health staff that were involved in the case. And that was difficult because obviously the social work assessment had just started, but they didn't know or were aware of all the healthcare professionals that were working with the family. And as it says there, at no time did all the professionals meet together to discuss the case. So that's, again, relationships. It's about building those relationships across professions. And then finally, on the last sort of few lessons, if a referral pre-birth by health colleagues had been made, and given that they knew the history of the parents, they knew what was happening for mother, they knew what her history was, they knew the poor home conditions and her emotional and mental health, that probably would have led to a pre-birth assessment and could have meant that things were put in place much earlier. And so in a way, that was a mistake, not putting that referral in pre-birth rather than post-birth when the injury had actually happened. There was a need for an overarching support package for the baby and the family. That would have been really helpful to have had something in place to have helped both parents, mother in particular, made sure they were supported, because there was no family network for them at all. So having something else in place would have been really helpful. The social work assessment, although it wasn't completed, the initial stages of it, there wasn't any consultation with the health professionals, and that may have been because they weren't aware of all of them, but actually finding out who those key health professionals were that were involved with the family would have been really helpful. And the last point is really, as we've said, about impact on professionals, that Maureen mentioned, that this talks about supervision, that the engagement with and across services should have been explored more fully at supervision sessions to make sure workers were supported, particularly when working with families that are struggling and parents that are struggling with their mental health and their emotional health. So the bit about making sure that professionals are okay, as well as family and children and babies. So that's just a quick summary of how similar it is to the other three cases, and we really wanted to include this baby because it's just important to make sure she was included. He was included, not she, sorry.
Thanks very much, Tracy. What I'm going to do is just ask the representatives of the agencies just if they wanted to comment on the KW case. And then we're going to turn the recording off because that will be the end of the recorded webinar. and have an open dialogue on the issues that have come up for you, having seen and listened to what's been presented. So just first of all, any reactions? I'll start with Cindy because of the issues for health from the KW case. Cindy.
Yeah, so I've just seen a message from Louisa in the chat, just saying that there were a few inaccuracies in those slides. So I'll have a conversation with you, Louisa, outside that, and make sure that we correct any of those. So I think there is you know, a lot we can do within health to try and ensure that we know who is working with a family from health, and we're able to share the names of all of those professionals so they can be invited and involved in those discussions. I think that we can take a responsibility to do that. However, I think so in this case that there were times when actually, even though those professionals were known, they still weren't involved or included in meetings and discharge planning meetings, for example, and yeah, meetings around the support. There's a lot we can do more of around trying to join up that supervision, for want of a better word, where we can share and reflect together as professionals, rather than having those sessions individually held within each healthcare or social care organisation.
Thanks, Cindy. Any comments from Ali? Ali.
Not hugely really. I mean, we added this baby in here because the learning was similar. So I'd echo what Cindy has just said, but also to say coming soon at some point, because of how the challenges of working with some parents. We have got some we've got hopefully some a webinar or a get together or whatever, or a workshop planned that I know Tracy is working with Norfolk Children's Services or Norfolk Safeguarding Partnership Board, that will be forthcoming in the near future. So I don't think there's anything more to add to it now.
Thanks, Ali. Okay, we're going to stop the recording and now move on to the open dialogue. For